Now, again, cancer is, I think it's pertinent because while you're going to have over a 30% chance of getting it yourself, the percent chance of you being affected, meaning someone that you're close to, having cancer, is practically 100%. I mean, is there anyone in here that doesn't have a relative that has had cancer in some way, shape, or form that you already know of? Huh? That has had cancer. Not necessarily died from cancer, but, uncle so-and-so has it, cousin so-and-so has it. So if not already, in your lifetime you will. There will be people affected by cancer. Now, I've already mentioned cancer is the process of a normal cell becoming a cancerous one. Means it does not know to stop dividing. It just grows and grows and grows and grows and grows. And that process is called carcinogenesis. We're going to talk about a carcinogen that's a cancer-causing agent. So in this case, the word literally means cancer, in the genesis, the formation of cancer. So out-of-control cell division just clogs up the works. You have too many cells in the wrong place, and the normal cells can't do their job. But then as we go from the division phase into where the cells are going to detach and spread throughout the body, now we start to get into some cellular changes. Most cells typically don't migrate from place to place in your body, but cancer cells do. And cancer is literally the spread of a tumor, because we can have tumors that haven't spread. We don't call them cancer. So it's important we know the distinction. When we have a cell that is affected, begins to undergo a change, it begins to grow and grow and grow. When you see a mass somewhere on or in your body, what do we call that? A tumor. It's simply a tumor. A tumor does not equal cancer. All right? Are we good with that? Do we all agree? A tumor does not equal cancer. A tumor is just an accumulation of cells that has lost the ability to divide. And if you think back to our discussion about mitosis, we had those checkpoints when we were going from G1 to S and to G2 and mitosis. These checkpoints made sure that all of our chromosomes were duplicated, that our spindle apparatus was formed so it was going to effectively separate. And if the answer is no, and some of those checkpoints in the cell didn't divide, well, those checkpoints have been lost. And so the cell just grows and grows and grows, and it doesn't matter what's around it, it's just going to keep growing.
So if you have a tumor that's it's benign, how does it eventually just stop growing or go away and stuff?
We're going to talk about benign tumor in just a little bit. Can you hang on to your question for us to get there? Okay.
How long does it take for them to develop?
Depends on the particular cell, depends on the mutation that caused it and what has happened. Some can grow. There's some slow-growing cancers, for instance, and there's some that are extremely rapid. So it really just depends.
Is there a specific nucleotide that is responsible for cell division?
No. There's certain genes and resulting proteins that do direct cell division, and these checkpoint genes that stop it. But as far as there being one specific nucleotide, I don't know that there's been one that's really been identified to say if you mutate this one, the whole works go kerblooey. All right. So here's the benign tumor, your question. Benign tumors grow rapidly, form a tumor. And typically when you see these types of tumors, we use this term hyperplasia. That's a clinical terminology. And we know what hyper means, right? What does hyper mean? Above, faster, too many. Plasia means function or form. And so a benign tumor is simply cells that are dividing out of control, that are growing too fast, but they're not going to spread throughout the body. So in this case, we have a mutation which is going to be the leading cause of cancers. You mutate that DNA in some way, shape, or form, and now we get a hyperplasia. Hyperplasia, benign tumor. If it stays in this hyperplastic state, then we're a benign tumor and we're not concerned at this point with cancer. So with a benign tumor, what do? Cut it out. Just cut it out. Remove it. A lot of it's going to be cosmetic. If you have a tumor, let's say, in your brain, that tumor as it enlarges, it could be pressing against other places in your brain, causing trouble, but it's still not cancer, even though it's not really a good thing to have there. Benign literally means it's not cancer.
So, like, if they just leave it in, how does it?
Depends on how fast it's growing. It won't go away. If it's not pressing on anything, if it's not causing any damage, any harm, then you may just leave it. But
I have one in my and they just left it.
then it's not, there's no risk of any danger, no harm, no foul. It's like a mole. I mean, most of us probably have moles somewhere on our body. That is a form of a benign tumor.
What about cancer kills you?
What about cancer that kills you?
Yeah, like what does it actually do?
So we'll talk about some different types of cancer, but typically the cancer cells, when they spread, they can get in your lungs so you're not effectively undergoing respiration. Or it can get into your bones and the cells can make your bones brittle. It can invade your brain and begin to push on the brain tissue and take over that space so you lose brain function. Gets into your kidneys, you're going to lose kidney function. Leukemia in the blood, you're not going to have sufficient room for blood cells. It's really just taking up space. Just getting in the way of all the normal functions. Imagine trying to drive your car if you opened up the hood of your car and just threw a socket set into your engine and then closed it. That stuff's in the way, may or may not be in the wrong place, may hit your fan, may knock out a radiator hose, but if it does get in the wrong place, you're going to have a lot of trouble. Right. Now, look at this bottom one. There are instances where a benign tumor can become cancerous. We have moles, we mentioned moles. If that mole starts to change color, if that mole starts to change shape, if it starts to grow all of a sudden, you need to get it looked at because something has changed to cause that to happen. Now, this is where we get the cancer. A cancerous tumor we also call a malignant tumor because those cells have lost the ability to stay together and now they spread throughout the body. That is the definition of cancer. And so when cancer cells spread, we first go into a process where we've got this hyperplasia, and you see how they've made the color green? So the first cell was green, all that clump of cells are green, but now we move to a stage where all of a sudden we've got the cells in the middle that are purple. You see that? And they're different shaped. So as we're moving from a benign tumor or to a malignant tumor, a cancerous tumor, we see the cells start to change their function, change their shape, and that's called dysplasia. Dys is different. And ladies, I know that y'all periodically go in, you have your pap smears, which you need to do on a regular basis. Has anyone so far had a pap smear that came back and they said it's precancerous, but we're just going to watch it? There's some cells that don't look normal, but they don't look cancerous, so we're going to check it again the next time you have to have a pap smear. That's probably going to be your first encounter with something of that nature. And when they say precancerous, understand that's that big fancy word dysplasia that we use. So, blood cells. If you have a leukemia, you can have a whole different look to our blood cells. You can have some of these big, humongous ones in there. These should usually stay in your bone marrow. We have way too many of these lymphocytes. And now down here we have way too many of these neutrophils. Some are not completely formed. Again, an indication of leukemia because it's different than what we would normally see. Did you have a question? I think the age at which it's recommended you have your first pap smear depends on your family history, just like your breast and mammograms. If you've got a history of breast cancer, and guys, you realize you can get breast cancer too, right? So the incidence of when you get your mammogram and how often you get them depends on your family. If your mother, first level relative, aunt, sibling, if they had breast cancer, you need to get checked sooner and more often. And the same would be for uterine cancer, cervical cancer, ovarian cancer. You'd want to get checked sooner than later. All right, so we've got our progression. We have a mutation on the left. Growing too fast, hyperplasia, cells start to change, dysplasia. Now we have a tumor, and I hate this term. Cancer in situ. In situ means in place. What did I just tell you about the definition of cancer? You only say cancer if it's spread. So this is an oxymoron. It's cancer that's in place. What they're trying to say here is that these cells are on the verge of spreading. They simply hadn't had enough time to get out of the main tumor yet, but they are in the process of spreading. So they use this term, cancer in situ. That's a term that most pathologists would use. But if you notice in our illustration, we can see a little bump with hyperplasia, and this would be skin cancer in our illustration. We see an even bigger bump with dysplasia. We see a tremendously large knot tumor that's going to look different on the surface with cancer in situ. You've got quite a bit of time to get this fixed. And if you can go in, and a surgeon is going to take a wide margin of tissue around a tumor. And so if you get it done here, there's just going to be a little bit that the surgeon takes. If you wait until cancer in situ, it's going to be a whole bigger chunk that he's going to have to remove. Because what you want a pathologist to report back to you is that they removed the tumor. It was or was not cancerous, but the most important information is the margins were clear. So they're going to remove this big chunk, and as you look, you see where my highlighter is going around here? That's going to be the chunk that the surgeon would take, and when the pathologist examines the edges or the margins and they see only normal cells, you can be assured they got all the cancer. And so it's going to be a lot easier to get your clear margins sooner than later, so don't wait.
So would that be like the same for tumor in the brain? Or?
Yes, tumor anywhere. For me, I don't know if you've ever talked to me close enough to see, but just here on the right side of the tip of my nose, there's like a little divot. Years ago, I don't even remember how long ago, there was something that looked like a zit, just a little white spot. And so what do you do when you have a zit? You get the pus out, right? So I got a needle, kind of tried to dig it out, but it started bleeding instead of being pussy. And I'm like, that's not good. So I went to my primary doc. I said, I don't know what it is. I don't want it. And so they cut out a chunk of tissue right there on the side of my nose. The worst pain I've ever been in my life when they gave me the deadening shot in the cartilage of my nose. I immediately started almost hyperventilating. My tear ducts just started pouring. I was like, okay, I don't know why. I'm not upset. And they said, it's normal to have that done. But the pathologist reports came back, basal cell carcinoma, cancer, with clear margins. So I got it soon enough. Basal cell is one of those slow-growing cancers. Who asked the cancer question? Yeah. Basal cell carcinoma, slower growing, so that was good news. But the clear margins was the best news. So how do you cure cancer? Early detection. Early detection. So the spreading of cancer, we call that metastasize, or metastasizing is the process. And the cells that actually do the spreading are called metastases, as plural. So again, I think you can appreciate it's really easy to get that one solid tumor out, but once the cells spread, how are you going to get them all out? You're not going to surgically go in and remove every cell that's spread. That's impossible. That's why you go to chemotherapy trying to kill the cancer cells, but right now we don't have targeted chemotherapy agents. The chemotherapies you take are killing the cells that divide quickly. But you have some cells in your body that also divide pretty fast too, that are normal and not cancerous, and they're killed too. Hair cells. Because someone on chemotherapy, what happens to their hair? Falls out. What else happens to somebody on chemotherapy? Do they feel good all the time? No, they get sick. What kind of sick? Nauseous, because the lining of your gastrointestinal tract, your digestive system, the cells that line that divide every 5 to 7 days. So it kills the lining of your digestive system. You have nausea, you have diarrhea, you have vomiting, you lose weight. So that's how you can kill the cancer, but you almost have to kill the patient to do it because it's killing all of the patient's normal cells as they're dividing. Now this is new information, so it's not in your PowerPoint pages, but I found this from the American Cancer Society today. This is a little bit more updated numbers. But this is what I was mentioning earlier. Men, almost a 40% chance of having cancer yourself in your lifetime. Ladies, not far behind at 37.6%. And is anybody surprised at the 2 top cancers for each gender? I'm sorry, sex. Gender's a whole different ballgame now. I forget. Breast cancer, ladies, would that be your first guess? Most commonly occurring. You have a 12.5%, ladies, of getting breast cancer in your life. Guys, not to be left out, we have almost a 12% chance of prostate cancer. You mentioned how soon to get checked, your pap smear and mammograms and all that. My dad had prostate cancer. I go to the urologist on a regular basis to have my prostate-specific antigen in my bloodstream checked. Early detection, that's what it's all about. Notice the next 2, though, the same. Whether you're male or female, lung cancer and colon cancer are the next. But males typically run ahead, especially with lung cancer, because what's the leading cause of lung cancer? Smoking. Traditionally, men have smoked more than ladies, but ladies, all this equality around, you're catching up. Aren't you proud? But that's one you don't want to equal, right? But lung cancer is still way up there, and colon cancer, you have about a 5% chance of getting colon cancer in your lifetime. So these carcinogens, these things that cause cancers, we're going to talk a little bit about them. But first, let's look at how your body protects you from cancer, because your DNA is getting attacked every single day from environmental factors. But you have genes that are more susceptible to that, but you also have genes that are there to protect you from this damage. You mentioned the single nucleotide mutation in the cell division. There's some of those genes that are more susceptible to mutation than others, and they're called oncogenes. Onco is cancer. If you get cancer, what doctor you go to? An oncologist. So any of these regulatory genes that are susceptible to obtaining a mutation are referred to as oncogenes. So we have our cell, and typically it's not going to be the single mutation. It's going to take this over time and over time, but all of a sudden we get enough of these attacks that damage the DNA in the right place or a sufficient amount. Boom, we go from dysplasia, now we go to our malignant tumor. And again, depending on the mutation, depending on the gene, that could take time or it could be a fairly rapid process. Now, typically, we're not going to see those high cancer rates because we also have genes that are referred to as tumor suppressor genes. These are genes that, in fact, encode a protein that checks your DNA, and if there is a mutation found or damage found, this protein acts as an enzyme to repair it. Almost like a seamstress that's repairing a rip in some of your clothes. And so when we look at tumor suppressor genes, I mean, here in fact is one that we're looking at. P53 is the name of this one. You don't need to necessarily remember that. But we have the tumor suppressor gene. Here are the genes. It makes the protein. That protein will then come along and repair a segment of DNA that was damaged. But what if the mutation from the carcinogen damages the tumor suppressor gene? Now you're going to be at a much higher risk of cancer. Because now we get damage, we don't have the repair mechanism of the tumor suppressor gene because it's loss of function mutation here. So if we get enough of this left unchecked, have a higher incidence of cancer. How many of you have you heard of BRCA1 and 2? They usually say BRCA1 and BRCA2. Anyone ever heard of that? Anyone ever heard of Angelina Jolie? Okay. What did Angelina Jolie do not that long ago from a clinical standpoint? She had bilateral radical mastectomy. Angelina Jolie had both of her breasts removed. Now, she's got enough money that she actually had plastic surgery and had everything all placed, but that's all fake now. Why did she have breast cancer? No. But she looked at the genetics from her parents. She looked at her own genetics, and she had a mutation in one or both, I can't remember, of the BRCA genes. BRCA genes are tumor suppressor genes. And if you have the mutations in BRCA1 or 2, your risk of breast cancer goes up 75%. And so she didn't want to run the risk of even playing with the chance of possibly getting it, since she was at an increased risk. Now, will insurance pay for that if you have a mutated gene? No. But she had enough money, she could do it. So if you know that some of your parents, your mother, if she has a mutation in BRCA1 and 2, you need to get your breast exams on a very, very regular basis. And then you've got some genetic consideration to think about as well. So what all kind of carcinogens are attacking us? Basically, what doesn't cause cancer is probably a much easier question. Viruses, bacteria, noxious chemicals, and then tobacco. And this number is probably even higher now, but 30% of all cancer deaths, not causes of cancer, but 30% of cancer deaths are due to tobacco. And the greatest of that's going to be cigarette smoking. Now we're going to start like meddling now, right? It's getting close to summer. Radiation, UV rays from the sun cause 80% of all skin cancers, including melanoma, which is going to be one of the worst. That one's a fast one. That's a very aggressive one. If you don't catch it early, that's the one that kills you. And then we have some internal factors, antioxidants, and we're going to talk about these a little bit as we go, kind of define those as well as some other agents that cause these problems. So here's our antioxidants. Now these antioxidants, vitamins A, C, and E, they're going to be good at getting rid of our free radicals. And actually on that previous slide, that should have said free radicals. Antioxidants are good. It's the free radicals that get you. And these free radicals are basically byproducts of many of our biochemical reactions that can cause damage that our antioxidants can come in and neutralize. So if you're not getting enough of these vitamins in your diet, you need to supplement your diet. But like with everything that we talk about from a nutrition standpoint, as well as a biology standpoint, natural materials are always going to be better than supplements. So if you can find those natural foods rich in A's, C's, and E's, that's going to be much better for you in preventing cancer. Now, I have a little bit better news than the data I've got for you here, because this data was a little bit old with this slide. Over the past 30 years, cancer rates really haven't changed, which means they haven't gotten worse, but they haven't gotten better. And when you look at this, again, the overall change not being better, but when we look at lung cancer in females, that skyrocketed 150%. I mean, that's crazy. Skin cancer is going out of control. But that data, if you look at, that's from 73 to 98. Now, I couldn't find world reports or I couldn't find U.S. numbers. And so this is a new slide. And with this slide, and this is from a Cancer Research Center in the UK looking at years 2003 to 2005, so a little more recent than those previous numbers. But during those 2 years in the UK, you can see all cancers decreasing rate of 10%. So we may be winning a little bit in the prevention of cancer, but a 10% decline is, It's not much. We're killing ourselves, and we know we're killing ourselves, but we don't stop killing ourselves. And in the UK, man, there's a 53% increase in these 2 years in liver cancer. We don't have to guess what the cause of that is, right? Alcohol. Is somebody just forcing it down the necks of these people? No. Just like is anybody, these people with lung cancer, they're forcing them to smoke? No. Are y'all aware of how addictive smoking is? I mean, maybe you don't personally have that experience. Maybe you've observed people that smoke and you wonder, why don't they just give it up? It's expensive to start with. But my sort of most incredulous example that I've ever seen in my life, well, I have two examples. The first, when I was in graduate school in Milwaukee, Wisconsin. It was about 28 below zero, and our building was a smoke-free building. But about mid-morning, there would always be a collection of people outside in 20 below doing what? Taking a smoke break. I'm like, that's jacked up, that you've got to smoke so bad you're risking frostbite just to smoke. But here's one that tops that. I told you I worked at the Cancer Research Center. Well, it was also a building that housed patients, and I was leaving one day. I was going through the main entrance to go down the steps, and there was a gentleman in front of me with a surgical gown. He had his house coat on, thankfully. I didn't want to see, that side. Had an IV pole, and he was smoking. I could see the smoke as I was walking up to him. As I walked past him, I just looked back to see who it was. This gentleman was smoking through his trach tube. Through his trach. If you're being treated for cancer, and I'm guessing throat, lungs, some kind of respiratory cancer, but you're out there smoking through your trach, that tobacco has you by the you-know-whats, and it's not going to let go. So, please, 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 if you don't smoke, do not start. Because if it gets a hold of you, it's not going to let go. All right? All right, get off my soapbox a little bit. Have we pressed the message home good enough? The way you cure cancer is early detection. You got to pay attention to your body. You've got to pay attention to your body. Don't ignore it. Don't think it's just going to go away. Don't think, man, I don't want to go to the doctor and pay that copay. Hey, it's better than risking your life. Okay? And there's so much stuff they can do. Genetic testing, we talked to BRCA. You can get that genetic test. I mean, we've got the x-rays, we've got the MRIs, we've got our pap smears, we've got mammograms, which would be part of this tumor imaging. There's also enzyme testing that can be done. There's so many diagnostic ways. Most of these are non-invasive that you can find out, okay, is this something that I need to worry about? Is this something that I need to explore further? This is an x-ray. On the left side, that's what your lungs should look like. Is that a good sign to have this big white mass inside your lungs? That's a bad day. This is a normal x-ray. This is going to be more of what you would see with an MRI that's been computer enhanced. Get quite a bit more detail of what's going on here in that left lung. Here we have an MRI that's showing how you can slice through digitally and electronically slice through the brain. We got anything in there that doesn't look normal? It's not going to take 4 years of med school and 7 years of residency to know we've got a tumor right there. And do you see how on this side, the normal shape of this tissue, but do you see how the brain's getting squished? Because that tumor's growing between the skull and that area. So it's going to be damaging. It's going to be inhibiting what's happening in that part of the brain. This is a PET scan. This is pretty interesting. With this PET scan, you can use radioactive materials that are going to be able to be trapped in certain areas. And in this case, we have multiple tumors. And I'm not sure. I would guess that our primary tumor is either going to be in this part of our intestine possibly down here, and I think this is testicular cancer, but you see how a lot of it's spread to the lungs? So again, with imaging, you can get a ton of information these days. So we would love to have this treatment to target the cancer cells. We don't have it yet. But with our regimen of chemotherapies or radiation therapies or a combination of both, right now approximately half of all tumors we can put into remission. Now, does remission mean cured? Remission is, I don't see anymore, we're going to hope it doesn't come back. That's what we mean by remission. But if you just have a few cells left, it could come back. You're just sort of counting down the days to see what happens. So our treatment sort of, as we go up in severity, surgery, that's going to get the cancer in situ, the hyperplastic or dysplastic tumors. Radiation therapy is sort of the next level. Radiation therapy, if it hasn't spread, once we get spread, then we got chemotherapy or the combination therapy, which is 2 or more of the above. And in many instances, you're going to do all 3. And a lot of times what they'll do with chemotherapy, if they find a tumor, they'll give you chemotherapy in the hopes that it shrinks the main tumor. So then you can go in with surgery and try to remove it all and get those clear margins. Now, I'd say over the last, 25 years or so, there's been a lot of growing research about how tumors secrete factors, these chemical signals, that actually cause existing blood vessels to branch and start to grow these new branches of blood vessels out to feed the tumor. These are called angiogenic factors. And so many treatments now are getting geared at trying to block these chemical angiogenic factors, and in doing so, if you can block the growth of these new blood vessels, you starve the tumor to death. Because the tumors are cells, they're going to have to be next to a blood supply so that they can get their nutrients, get rid of their waste. And if you strangle them off and suffocate them, then you're going to reduce the size of that tumor, if not eliminate the growth altogether. So that's an area in which there's been some promise, but of course, if you're getting these anti-angiogenic factors and you injure yourself, how are you going to regrow your own blood vessels when you need to? So there's risk involved in that process as well. All right, you ready to go down our list here? I will go ahead and warn you, some of these pictures may not be the prettiest pictures, and I saved the best one for last. And I even put a graphic image warning sign before I showed the last picture of the semester. But it's going to hopefully really reinforce the point of early detection. Okay? Skin cancer. Basal and squamous cell carcinoma, like what I had on the end of my nose. 95% cure rate when you detect it early. Melanoma. 95% cure rate if it's localized and what? Detected early. If you don't detect it early and you let it spread, your chance of survival goes from 95% to 16%. Yeah, not good odds. So here you have just this waxy lump. Here you have a firm red one. Here you've got some bleeding. If you see something that starts bleeding on its own and you didn't cut it, nick it, and you can't get it to stop bleeding, get to the doctor ASAP. Breast cancer. And again, this is for both males and females. Do you know why females typically have higher instances of breast cancer? Just from a statistical standpoint, females typically have more mass to their breast tissue than do males. And this is going to be all the tissue on top of the pectoralis muscle. So that's why women get more breast cancer than men, because you just have more cells that can undergo carcinogenesis and undergo metastases. So from the point of detecting breast cancer, if you are diagnosed with breast cancer, you have a 15-year survival rate of 56%. That means for all the people that are diagnosed with breast cancer, when you look at those individuals, 15 years later, half are dead. That's what that survival rate means. For all breast cancer, the 5-year survival rate, so 5 years later, how many of those are still left alive? It's almost 100% if cancer in situ, which means what? Early detection. If you don't detect it early and it undergoes metastases, your 5-year survival rate is 21%. 79% of those people that are detected with metastases in the breast are dead within 5 years. That's scary numbers. So this is looking at ages. Age 30 to 40, your chances are 1 out of 257 of getting breast cancer. 70 to 80 chances, 1 out of 24. Because guess what? The older you get, the more your cells have had to divide, the more chances there's been to encounter a carcinogen, more chances of being out in the sun and those ultraviolet rays damage the DNA. So the older you get, you're on borrowed time. So what do? So typically, here's our number. If you're just the average female in your 40s, you need to start having your mammograms, and they're going to have you do it every 1 to 2 years. If there's an increased risk because of a family member having breast cancer, maybe you know you have the BRCA1 mutation, you're going to start before the age of 40, and you may have a mammogram every 6 months. Again, better safe than sorry. You don't want to play around with cancer. So with your mammogram, 5 to 10% of all mammograms are going to come back abnormal. So if you have a mammogram and they say, you know what, we're going to send you in for a CT scan, don't freak out. Because a lot of these abnormalities are going to be benign fibrous cysts within the breast. There's going to be a less chance of the breast cancer, but even so, if you find a mass in situ, even that cannot be a bad thing and get it removed. All right, guys, not to be left out, right? So, guys, while you can get breast cancer, guess what? Ladies aren't going to get prostate cancer. No, they've got the whole uterine cancer, cervical cancer, yeah. So, guys, the greatest risk for prostate cancer is getting old, unfortunately. The good news about prostate cancer, it's slow grower. 5-year survival rate for all prostate cancer diagnoses is 90%. And there's some guys that will get diagnosed with prostate cancer in their late 70s and their 80s. The doctor will say, we're not even going to treat you. You're going to die of something else before the prostate cancer will get you. If you're younger, there are various radiation procedures that they can do, robotic surgical procedures they can do to remove the prostate gland and basically cure the cancer. Now, guys, here's the good news. You go in to your urologist to get checked. They'll do a blood test to look for prostate-specific antigen. If your dad had prostate cancer, you need to start doing it sooner than later. Because what they'll do is they will take a baseline PSA number, and you'll go in every 6 months to a year. They'll draw some blood, see if that PSA is staying the same. If the PSA starts to jump up, then they're going to say, okay, something's happening with the prostate. That's the good news. The bad news is that's not the only test they're going to do. There's something called a digital rectal exam. It's got nothing to do with electronics. Do I need to say anything else? It's not a pleasant idea, okay? But the size of the prostate is another diagnostic value that they can plug in with your PSA to really know, is there something going on with the prostate, to move on to the next level of imaging or to move on to the next level of treatment. And you got to start doing those sooner than later. Lung cancer. We already got this, right? Smoking. Smoking is what does it. Now, are you ready for this horrific number? Look at this 5-year survival for lung cancer. The 5-year survival for lung cancer of all those diagnosed, 86% are dead within 5 years. You got very little chance of surviving if you're diagnosed with lung cancer. Now, the lungs are also a place where metastases like to get stuck because there are a lot of capillaries in the lungs, right? So that we can exchange oxygen and carbon dioxide. So a lot of these metastases get in the bloodstream and they get stuck in these capillaries and start to grow. So in most cases, that lung cancer is the last stop and your last chance. Because you can't live without your lungs. So stop smoking. Stop smoking. Every year you smoke, you shorten your life by 5 years. For every year you then stop smoking after that, you get 5 back. Now, if you don't smoke, don't think you're going to live to be like 300 years old. No, it doesn't work that way. That was a joke. You can laugh. Cancer's nothing to laugh at. Colorectal cancer, number 3. That was number 3 on the list for men and women, right? Colon cancer. So colorectal cancer, you know, it's a slow grower. 5-year survival, 62%. That's a lot better than lung cancer. And typically when you reach 50 and over, so I'm on borrowed time, you get to go in for this lovely little joyride called the colonoscopy. I wanted to be an astronaut when I was in college. I actually got my astronaut candidacy application. I got it all filled out, letters of recommendation. The internet was still fairly new, so I got online and found out anything and everything I could about the astronaut candidacy program. Well, the first thing that sort of dissuaded me was a lot of these people have like 3 and 4 PhDs. I'm like, what? But then as they were talking about the health checks and the health exams, they were talking about this in the astronaut candidacy program. The astronaut candidates affectionately called the colonoscopy the steel eel. As I was done. I was out. Now, the good news is they give you general anesthesia for this. You're gone. You're not going to remember this because they're going to check out the colon and ascending, transverse, descending. So the steel eel has to make, we'll just leave it at that. But here's the bad news. What are the diet risk factors for getting colon cancer? Well, if you eat fatty foods, protein, calories, alcohol, red white meat, what's not going to cause colon cancer? Tofu. Tofu is protein. Tofu causes cancer. So once again, you're going to get it. You're going to get it. Now, the cancer societies, they recommend low-fat, high-fiber diets. I'm waiting for a study to come out that says fiber causes cancer because basically everything causes cancer. But that's what we would like to do, low-fat, high-fiber. Lymphoma, you hear oma, you know that's going to be a tumor. Lympho, this means in your lymphatic system. And this is like the internet in your body, the superhighway. If you get metastases in your lymphatic system, pretty much game over. You're going to be headed for chemotherapy, radiation, or both. Because that's going to spread throughout your body fairly quickly. Bladder cancer. This is going to be number 7 on our most frequent list. Uterine cancer. Leukemia. These are cancer of our white blood cells. And then, oddly enough, number 10, oral cancer. Again, what is the leading cause of oral cancer? Tobacco. Now, this is a fairly innocuous mouth cancer. We're not actually in the oral cavity yet. But I'm thinking, how can someone just live with that and let that go, thinking that's okay? It does almost look like a cold sore, but I wonder how long that person... Cold sores don't last that long. I'm sure this person has had this for a long time. Now, I got 1 slide left, and the semester's over. What is the way that we cure cancer? That's not it. I found a much better one.
I can't really tell what this looks like in the way
That was his lip and his tooth. No, this one's much, much better. What is the way you cure cancer? Early detection. Now, if you are squeamish, you may in fact want to look away. This one is almost more than I can look at. This is a gentleman that apparently chewed tobacco for maybe 300 years. No. No. Yeah, you just cover up. I won't leave it up too long. Okay? If you're squeamish, I promise you do not want to see this. But if you are hesitant about this whole early detection thing, you remember this picture for early detection. Because if you don't detect your cancer early, this has eaten the entire side of this guy's face off. That's the cancer. If he's not, he needs to be. I don't know. I mean, you will be shocked. You will be shocked at what people try to live with sometimes rather than going to the doctor. Hey, we still made it.